Hey guys, welcome back for another week of topics and tips. As you know, this month I have been covering the non clinical series, going through all the things to get you prepared for that non clinical portion that you may see on boards. Most definitely, as I always tell you, the ANCC is saturated with non clinical content, being over 60% of the exam, as well as the AAMP has it. It's just presented a little bit differently. But this week we are covering HIPAA, CMS, and billing. So I will hit on those areas. I'm not covering everything. I do have a video where I go through basically all of the non-clinical series, and also it is found in my review book and courses. But I want to get you on the right path, so we'll hit these topics, and I'll kind of throw in some terms that I think that you should. Shouldn't even say think that I know that you should look into adding into your studying. Okay. But I'm trying to keep these short and sweet and not overwhelming to you guys. So let's get into the stuff that you should look into in these areas. All right. All right. Hey, y'all. As always, I like to give a disclaimer before getting into my videos. So, for those of you who have been watching my videos, taken any of my review courses, done any of my things, hey, y'all, hey, y'all, hey, y'all. But to you guys who are new to me, welcome, welcome, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner, and I'm the founder and CEO of the Nursing Studio. I have designed these videos to help nurses and nurse practitioners be successful on boards as well as in practice. This can help you while preparing in school to pass exams, prepping for clinicals, things of that nature. But I like to tell you this is not an end all be all. There's nothing absolute in medicine. So this is not to be taken and utilized as an absolute factor, but to help you gear your mind, your studies, so that you can be successful in board preparation. Okay. All right, let's get into the topics. First, let's start into HIPAA. Working in nursing, we're familiar with the terminology of HIPAA. HIPAA is an acronym that stands for the Health Insurance Portability and Accountability Act. This was passed back in 1996. And HIPAA is all about the confidentiality. Last week we discussed confidentiality and what that term is and means under the ethics and legal review. If you haven't had a chance to look at that, go back and check out last week's videos because we cover all of those ethics terms. The beneficence, the non-maleficence, the confidentiality, the veracity, things like that. But with confidentiality, that says healthcare providers and workers, it is our policy that we are to keep the ones, our patients that we are caring for, their information confidential and only viewed and shared with those who are actively caring for the patient. And so that HIPAA Act was passed by Congress in 1996 to solidify that confidentiality and policy to keep us accountable for the patient's confidentiality. Okay. Next, let's get into a few billing policies and topics. All right. So with billing, that there are a few terms and things that you should know about. And here you'll see that I want to go over the claims space versus the current space policies as far as billing. But also there are some other terms that I think you should familiarize yourself with, such as, being familiar with the CPT codes and the ICD-10s. We are familiar with seeing and hearing of those, but I want you to truly know what they are and what falls under each. Okay, so take a moment to review those type of things. We'll also get into incident to billing in a little bit. That's a little bit more, and a lot of people get stuck on that. So I will get to that on another slide. I just wanted to make sure that you are understanding and thinking about that, and also familiarizing yourself with the HMOs and the PPOs, knowing one versus the other. Okay, but let's get into the claim space versus the current space, because when you think of billing, these two are things that you should really consider as well, and things that may fall into these categories. So just terms that you should know, and I know that people get stuck on. With claims based, so this is basically an insurance policy. It provides coverage for someone when a claim is made against the policy. So it's basically only beneficial to you if the claim is made when the policy is active, right? So these are typically used when there's going to be a delay between when the claims are filed, but claims-based policies are only beneficial to you if your policy is active when the claim is made. Now, occurrence-based policies, they cover all the claims and damages and injury, but this is coverage regardless of when the claims are made. As long as the claim is being made during the time that it occurred, if you had coverage during the time that the event occurred, that the claim is being made about, then you're covered. So if it's 2023 and there's a claim being made on something that occurred in 2025 and you had coverage under an occurrence-based policy, then you're still covered regardless if this claim was filed years later. Whereas with a claims-based policy, if that policy isn't active, then you don't have coverage when the claim is filed, if it's no longer an active policy. I hope that makes sense. Let me know in the comments if you need me to explain that a little bit differently or give you some more examples if it's confusing to you guys, okay? All right, Medicare. So Medicare, we're familiar with this, but you need to really know the definition of it and what falls in all the parts, etc. So we commonly know, like, hey, Medicare, once we hit 65 and older, we start to get Medicare, but it's a little bit more detailed. Medicare is a federal health insurance program. This is for the people who are 65 years of age and older, but it also can be for other age populations with certain disabilities, as well as those who have end-stage renal disease. Now, it's broken down into different parts. Now, when you turn 65, years of age, if you're disabled, if you have the end-stage renal disease, then Part A is what you automatically get. I say think A for Part A and A for automatically receive, and that's that generalized coverage. Part B is another part of it in plan, and it includes to provide coverage for like your outpatient style stuff, like your labs, your doctor's visits, like DME, like those wheelchairs, walkers, some surgical procedures, things of that nature. Okay. So I say B covers that basic outpatient necessities. C is the choice plan. So think C for Part C and C for choice. And this allows you to add in those additional services, which to me, I feel like these should be included anyway in the automatic stuff because we need it. But you have to include the Part C, the choice plan, to get these additional services such as vision and dental. Okay. So you can also, of course, keep your Medicare A and pay for Medicare B, but you'll have to opt in for the Part C to get that vision and dental included as well. Again, it's a choice to include those additional things, but to me, it really should be included. But just remember C for choice, C for Part C to add in those additional. And then lastly, Part D, I say think Part D for drugs because that's your prescription coverage. So those of you who have medication coverages or your patients need coverage for prescription medicines, Part D will need to be added to cover that. Okay. So again, Medicare is that federal health insurance program for those 65 years of age and older, any age group that is disabled with particular disabilities, and those with end-stage renal disease. And then it's broken down into Part A, B, C, and D. Part A is that automatic coverage that everyone gets if you meet that criteria. Part B is that basic outpatient coverage for some surgeries, labs, DME equipment, etc. Remembering C is the choice plan where you can choose to add in that dental and vision with your coverage. And then Part D is the drugs to cover your prescription plan, okay? All right, now Medicaid. Again, another thing that we are familiar with, but I need you to really know the ins and out of it. So Medicaid is a healthcare program that assists low-income families or individuals in paying for long-term medical and custodial care costs. Now, the thing with this is, just like Medicare, it is part of a federal governmental funding program, but Medicaid is dual because it is mainly funded by the federal government, but it's led and ran by the state. So it's a state by state basis. So things vary based on where the patient is located. Okay. Now let's get into this incident to billing. I told you I was going to get back to it, but I wanted to take a moment to do that last so that I can kind of just run through the details of that because a lot of people get confused with this. All right, so incident to billing. The the simplest way to explain this is typically if you're not a physician, so our nurse practitioners, our physician assistants, clinical nurse specialists, things of that nature, typically, well, not even typically, the way that Medicare policies and things work is that you are reimbursed at 85%. The physician is reimbursed at 100%. The nurse practitioner, PAs, things of that nature are reimbursed at 85%, right? Well, incident to billing allows for nurse practitioners, PAs, but let's talk about that. We can still bill at a 100%. You can be reimbursed 100% if it's incident to, meaning so if the physician is already actively seeing this patient and this is a follow-up and the nurse practitioner is doing the follow-up, refilling prescriptions, incident to what the original treatment plan, et cetera, consultation from the physician, then you still will be reimbursed at 100%, right? You're supervised under that provider, but you are able to receive 100% if it's incident to. Now, if the physician is not seeing that patient, then you will be reimbursed at that 85%. But a lot of times, a lot of facilities and organizations would like to do incident to billing, and the nurse practitioner maintains certain follow-up duties and things of that patient that the physician has actively been caring for some time and still being able to be reimbursed at the 100% reimbursement. So I hope that makes sense. And so again, it has to be part of that physician's normal course for the nurse practitioner to be able to get that full reimbursement. So that's the main thing, and it has to be appropriate documentation for those things for the incident to billing. So that is something that is commonly utilized in many organizations, and so you need to familiarize yourself with that. But I wanted to kind of hit in on it in the simplest way that I could to try to gear your mind and give you an example. Because a lot of times it's like, all right, well, what's the benefit? How does that work? What does that mean? The benefit is in anything that we do, we're trying to get 100%, right? And so organizations would prefer to get the 100%, but this allows the reimbursement to be of that for the services of nurse practitioners like myself to be able to, when we do our services, to get that full reimbursement if we are following the management and care that a physician has already initiated. Okay. All right, you guys. So again, we're doing the non-clinical series. So tomorrow we will do our Work It Out Wednesday questions, test your knowledge on these terms that we have done. And then, Thursday this month, I'm doing a series of study rounds where we're repetitively going over this to help you get these terms retained. But what you can expect for the following week, we'll be covering the professional topics to conclude our non-clinical series for the month. So that'll be a little bit more terms. That's the area that most people get hung up on. So I really want to get into that. But if you have any questions about the HIPAA, CMS, and billing area, please let me know and I will gladly go over some of those. But be sure, as always, to like, comment, subscribe. Make sure you share with whomever you may think may find this beneficial as well. And meet me back here. Bye, y'all.